Okay, we have one more session, or we have a panel discussion before we break for lunch. I'd like to introduce our current panel on hand hygiene compliance and monitoring. We've heard a little bit already about the conundrum with hand hygiene, and we have assembled what I feel are just our world-leading experts in this area. Dr. John Boyce, sitting here, he is a president of his John Boyce Consulting Company, which is a role that he's assumed after leaving as director of the Hospital of Director of Hospital Epidemiology and Infection Control at Yale in New Haven, Connecticut, and as clinical professor of medicine at the Yale University School of Medicine in 2015. He's also served as president for the Society of Healthcare Epidemiology of America, or SHE, in 1999, and he has been led as a co-author to the CDC Guidelines for Hand Hygiene in Healthcare Settings, which was published in 2002. He's, you'll have to read his bio. We have the full bio online. There's not much that you cannot say about the work that he has done. And I would like to reiterate the term that Dr. Sanjay Saint used to describe both Dr. Boyce and Elaine Larson as Hall of Famers in hand hygiene. I don't think we could have assembled a better team here with Paul Alper. So Dr. Elaine Larson, one of my personal heroes, is an associate dean for research at Columbia University School of Nursing and professor of nursing in nursing research and epidemiology at Columbia. Dr. Larson received the first Pathfinder Award from the National Institute of Nursing Research in 2003. She received an International Nursing Researcher Award from Sigma Theta Tau in 2011, and the John Stearns Medal for Lifetime Achievement in Clinical Practice from the New York Academy of Medicine in 2014. She is the director of the Center for Interdisciplinary Research to Prevent Infections at Columbia University, and most recently, literally very recently, in just last month, I believe, she was named a living legend by the American Academy of Nursing. Joining Dr. Boyce and Dr. Larson is Paul Alper. Dr. Alper has worked as a business leader, researcher, innovator, and strategist in the healthcare and consumer product markets for over 30 years. He is currently the VP of Patient Safety Strategy at DebMed and chairman of the Hand Hygiene Compliance Organization. During the past 9 years at DebMed, he has been leading researchers and pioneering in the electronic monitoring of hand hygiene, and in September of 2015, he was elected chairman of ECHO, the Electronic Hand Hygiene Compliance Organization. This is a not-for-profit consortium of hand hygiene technology companies. They will, we will hear from each one of them, and we will have some time for Q&A afterwards. So keep your questions ready to go. Thank you.
Good morning. I'd like to say I'm happy that the conference organizers invited me to talk at this meeting today. I'm not very happy that I had to follow Sanjay Saint because he is one tough act to follow. But I do appreciate the fact that he mentioned the importance of hand hygiene. As many of you know, one aspect of promoting hand hygiene is to do monitoring of people's compliance and to give them feedback. And so I'm going to be talking about hand hygiene monitoring this morning. So in monitoring hand hygiene compliance, presently, direct observation of hospital personnel by trained observers is currently considered the gold standard method of determining hand hygiene compliance rates. And it has some very definite advantages. They include the fact that direct observation can determine compliance with all 5 moments for hand hygiene as defined by the WHO. And with possible rare exceptions, the automated methods for monitoring hand hygiene really can't determine compliance with moments 2 and 3. Direct observation can also evaluate hand hygiene technique, how long they clean their hands, and whether or not they do it in a complete fashion. And it can also determine whether or not people are doing hand hygiene at the right moments during an episode of patient care. And if the observers choose to, they can also do real-time, or sometimes called just-in-time coaching, where they can give immediate feedback to the people that they're observing. And they can also try to identify various barriers to hand hygiene. Now, direct observation is affected by many variables shown here, and they include the methods and the time spent for training the observers, the frequency of any validation of the observers, if it's performed at all, the type of individuals that are actually serving as observers, the duration of each observation session, like how many minutes they stand on a ward, the Hawthorne effect, the time of day and week that the observations are done, whether or not there's any observer bias, the sample size, which is a major issue, and then logistical issues affecting the ease of observations and administrative support for the resources needed. Now, these variables affect the rates of hand hygiene compliance that are generated in hospitals. And because there's so many variables, right now it's completely impossible to compare compliance rates from one hospital to another. So if one wanted to standardize direct observation methods, these are the list of things that you'd have to try to standardize. So I'm going to go through each of these in some more detail. There are many methods used to train observers. The training materials vary. The time spent and the amount of cost spent training observers is highly variable. Some training programs try to teach the people to do overt observations. Other ones favor covert observation strategies. Some places teach their people to record the WHO 5 moments of hand hygiene, whereas other hospitals say just record compliance going in and coming out of the room. Some record things with a clipboard and a piece of paper and a pen. Other places use electronic methods like iScrub Lite or commercially available electronic methods of recording hand hygiene. And so standardizing observational strategies and methods for training observers would be desirable, but it may be pretty challenging. Validation of newly trained observers by experienced personnel is something that Elaine has brought out as an important aspect. It's done in some facilities. Other places don't do any validation. And for those that do validation, the methods and the time that they're spent validating is, again, highly variable. And whether or not once you validate an observer, whether they're ever validated again, like 6 months or a year later, again, is if it's performed at all, it's done at very different frequencies. So standardized validation and periodic validation of observers, I think, would contribute a lot to the ability to compare compliance rates between institutions. It would contribute to our ability, but wouldn't be the only thing you'd have to standardize. And then one could consider using kind of a same approach everywhere for validation, like having an expert observer and a trainee observe people at the same time. That's probably the most common validation method. Other people will use a WHO or Joint Commission training video to validate. The categories of individuals that perform observations include nurses. Sometimes the nurses do observations on their own ward, which often leads to an observer bias, or other times they will observe compliance on other nursing units. Other people doing observations include infection preventionists, all different kinds of students, because they're often free. And then at least one hospital I'm aware have used all types of healthcare personnel throughout the hospital, with everybody watching everybody else, kind of an unusual approach. So standardizing the type of personnel that serve as observers might be preferable, but I'm guessing it would be very difficult because of differences between hospitals and the amount of human resources they have available. The Hawthorne effect has been very well established to affect hand hygiene compliance rates, and often results in artificially high rates like 90–95% compliance. When you see those, don't believe them. They're almost always artificially high. Some of the factors affecting the Hawthorne effect include the baseline hand hygiene compliance of the groups being observed, whether or not there's a secret shopper versus overt observation, the familiarity of personnel with who the observers are, the beliefs of the personnel being observed, and whether or not they really care if anybody's watching them or not, and then the duration of observation periods. So in several studies, the duration of each observation session has varied from a 5-minute session to as long as 1 or 2 hours of standing there watching people. So the compliance rates increase as the duration of the observation period increases. And so some studies have found that in as little as a few minutes or maybe up to 15 minutes, if you start observing longer than that, the compliance rate goes up and up and up because primarily of the Hawthorne effect. People know they're being watched. So probably the easiest thing maybe to standardize in direct observation methodology would be to limit observation sessions to only 10 or 15 minutes per session. Then there's logistic samples and sampling issues that affect direct observation. They include the distance of the observer to whoever they're watching, their location on the nursing unit, how busy the unit is at that time, and the architecture, like whether or not there's privacy curtains in the way or walls in the way of observing people, and then the time of day and the day of week of doing the observations. So one could envision maybe trying to standardize work shifts and days of the week when observations are made. The sample size is a major issue. In reading I've done, it looks like direct observation captures somewhere between 0.1% and at the most maybe 2.5% of all the hand hygiene opportunities that are going on. Data from our group and others have shown that despite the fact that some hospitals say, oh, you should do 10 observations per nursing unit per month, In one study in Iowa where they used badges, it looked like in a month there were 40,000 hand hygiene opportunities in an ICU in a month. So if you're looking at 10, you're looking at a tiny sample of what's going on. Yin and colleagues estimated that in a unit with 40% compliance, if you wanted to detect a 10% increase, that you'd have to do around 190 observations, or about 50 hours of observation. So this is a big problem, is that direct observation takes a lot of time. They recommended that facilities should determine in advance the number of opportunities needed in order to get a good approximation of what compliance was really like. Personnel time and salary costs required to perform direct observation will vary a lot from one facility to another based on the size and the type of patients cared for. Many hospitals, including the ones I've worked in, have experienced a lot of difficulty in getting adequate administrative support for the resources necessary to do direct observation in a meaningful way. Methods and standards which would assure that there was an adequate amount of human resources dedicated to direct observation would be very helpful, but again, difficult to implement. So what about automated approaches to monitoring hand hygiene? These have a number of advantages. One is that these systems collect and analyze orders of magnitude more data than can be generated by direct observation. And they can do it 24 hours a day, 7 days a week. There's basically no observer bias with these automated systems, and there's little, if any, of the type of Hawthorne effect you see with direct observation. They can provide near real-time data analysis and feedback, and once they're installed, it takes very little time for data collection and analysis. However, it's important for you to point out that if you install one of these automated systems, that it requires additional supplementary hand hygiene program activities if you expect to see a real increase in hand hygiene adherence. If you just install a system and you think that's going to take care of everything, there's a number of studies that show that that doesn't work. Some of the limitations of the automated systems include the cost, the manpower, and IT needs and infrastructure that are required to install and maintain these systems. And I know there's a couple of systems that still require improvement in the accuracy of determining compliance rates, whether it's in and out of the room or that kind of thing. There's a lack of information right now about the long-term impact of these systems on hand hygiene compliance rates. We don't know much about their real impact on healthcare-associated infection rates and therefore their cost effectiveness. And there's still some issues about how well these kind of systems are accepted by healthcare personnel. And then one thing that's a shortage often cited is the inability of most of these systems to determine compliance with WHO moments 2 and 3. So one thing I've looked at is the issue about direct observation of all 5 moments versus the automated monitoring, which generally gives you a proxy for compliance with moments 1, 4, and 5, with moment 1 going into the room, moments 4 and 5 when you're coming out of the room. So currently, direct observation by trained observers, I think, is the only well-validated method for establishing compliance with all 5 moments. And so the question is, how does compliance with moments 1, 4, and 5 that you would get with an automated system compare with compliance with all 5 moments. One study done by Didier Pitte's group found that compliance with moments 1 and 4 was 61% in their hospital. And if you looked at the same database of observations, compliance with all 5 moments was 62%, only a 1% difference. So I tried to look at this issue further by doing a literature review, and I found 28 observational studies that reported the distribution of all 5 moments. And in these 28 studies, there was over 600,000 hand hygiene opportunities done by observation. Moments 1, 4, and 5 accounted for 81% of all the 5 moments. And in 18 of the 28 studies, they reported compliance rates. And when you looked at compliance with all 5 moments, it was 66.5%. When you looked at the same data and you looked at compliance with moments 1, 4, and 5 combined, it was 64.9%. So maybe about a 2% difference. So based on these observational studies, one might conclude that monitoring moments 1, 4, and 5 might give you a pretty reasonable estimate of compliance with all 5 moments. So in conclusion, I think that given its unique capabilities, that direct observation should continue to be used mainly as a qualitative measure of hand hygiene, looking at technique and appropriateness. And then automated monitoring systems have several important advantages. And I would like to think that if more hospitals get involved in trialing and utilizing these automated systems, that we will develop more data on their accuracy, their effectiveness and cost effectiveness, and that eventually these systems may become the main quantitative measure of hand hygiene compliance, with direct observation being the main qualitative measure. And so at this point, I would like to thank you for your attention.
Okay, I'm going to go back a little bit to what Sanjay was talking about, the human monitoring and hand hygiene interface. I don't have any disclosures. Right now, all my funding is coming from the government, the Agency for Healthcare Research and Quality, for any research that I'm doing. The reason I want to talk about this, the behavioral aspects of use of hand hygiene monitoring, is because I know that many of you are in industry, and you may think, well, this behavioral stuff is not selling products for us, but I really think that your marketing people will be much, much more effective when they communicate to the people in the clinical settings where you're working and people that you're talking to, that you understand the place of your products in the system of care, and that you understand that just a product by itself, without some understanding about how it is going to be integrated and implemented, isn't going to work. And I think that's going to be a very strong selling point. So I want to talk a little bit, just go through some older behavioral theory in the last decade or so, and then link it with, in this case, sort of electronic monitoring for hand hygiene and where that might fit in with a system of care. So this was an interesting study done over 10 years ago and published in Science, called the Macbeth effect. And it was, in this experiment, they took 60 people and they were asked to recall either an unethical or an ethical behavior that they had done. And those that were asked to recall unethical behaviors were 1.5 times more likely to select a cleansing-related word at the end of they were given a bunch of words and say, pick a word. So they were more likely to select wash, shower, soap versus wish, shaker, or step. Those who recalled unethical versus ethical behavior were twice as likely to select a gift at the end of an antiseptic wipe rather than a pencil. So their sort of conclusion, after describing the unethical deed from their past, then participants either cleansed their hands or they didn't. And those who cleaned their hands were half as likely to volunteer to help someone else. And they sort of hypothesized, the authors, that cleansing your hands had restored their feeling of moral, commitment or whatever. So they concluded, I think this is a really interesting kind of fun. They concluded that physical cleanliness, such as hand hygiene, has psychological and behavioral consequences. And they said, in conclusion, it remains to be seen whether clean hands make a pure heart, but our studies indicate that they at least provide a clean conscience after moral trespasses. So what drives hand hygiene? And our colleagues in Australia have published a couple of papers, first of all saying that emotional concepts of dirtiness and cleanness are one of the primary drivers of hand hygiene. So that if you feel that your hands are dirty, if they're physically soiled, whether they're full of microorganisms or not, you're more likely to clean your hands. And hand hygiene behavior, when you're touching something dirty or perceive that your hands are dirty, they call it inherent, as opposed to elective hand hygiene, where you follow the guidelines, such as the CDC or WHO hand hygiene guideline, and it sort of goes against sort of the natural tendencies, which is partly why I think Sanjay was talking about mindfulness, because we found the same thing in our nursing students. We asked them to look for near misses, like not doing hand hygiene, and in themselves and in each other, and record it, and they are much more likely to be mindful of when they've actually missed it. So this same group said, and this is a quote from them, the hand hygiene practices of healthcare workers are learned behaviors from childhood, which are continued in a professional context and reinforced in everyone's daily lives. We strongly caution against unrealistic expectations that entrenched, long-standing behavior patterns will be changed in a sustained fashion solely by the introduction of a new product or system. So given all that, what are the factors that affect one's ability to make a change in something so intrinsic as hand hygiene? Well, it's a lot of things. First of all, the capabilities and limitations of individuals. Do they know how, et cetera? And are they physically able to get where they need to go to do it? The environment, the culture, the tasks, do they know how to do it properly? And in fact, most curricula now in nursing and medical schools do not teach hand washing technique anymore. And there's very clear evidence that it's not just the frequency with which you do it, it's the technique that really matters. And then the monitoring devices and some of the technology that we are talking about today is where one can really make a difference in both the environment, the culture, and the availability of tools. So another interesting studies, a group of studies, I think they were done in the UK. You may have heard of these. They collected baseline data from service stations, gas stations. They tested interventions that were derived from different domains of behavior change theory to determine the effectiveness at increasing hand washing with soap in a natural setting, in the bathrooms. They installed wireless devices in the bathrooms to record the entry and whether soap was used before people went out. They had 2 text-only messages for each of 7 psychological domains, and they were compared. They recorded over 200,000 restaurant uses. So interestingly, the knowledge domain was most effective for women. It increased the use of soap by 9.4% compared to any other messages. The disgust domain worked better for men, and that was significantly an increase in hand hygiene. Neither of them worked that well, less than 10% increase, but totally different. So disgust was not significantly different than the control group for women. So they concluded that messages based on social norms and social status were effective for both genders, but there were differences between the genders, so there may be the need for different kinds of interventions for men and women. So there are a number of other studies from 11 countries among childcare takers, one that showed that disgust was a key motivator for hand hygiene. So they're much more likely to do it if they change a diaper than if they, wipe a child's nose or are feeding a child. And a video to induce disgust was significantly more effective than education at increasing hand hygiene. Personally, I'm not a fan of the disgust thing, but nevertheless, it's very interesting that different things affect different people. So what are the barriers in healthcare professionals for doing hand hygiene, for changing their behavior? First of all, lack of awareness, and this is a barrier for pretty much any kind of behavior change. Do you know what you're supposed to do? Lack of agreement. Okay, people tell me I'm supposed to wash my hands. I don't, agree. I don't think the data are there. I don't believe the data. Lack of self-efficacy. I don't know how to do it, or I don't have the time, or I don't have control over the environment to do it. Lack of outcome expectancy, and I hear this a lot. It doesn't matter how much I do hand hygiene because everybody else isn't doing it, so my behavior isn't going to make a big difference. Or just inertia. It's the way I've always done it. I've never had big problems, so I'm just going to keep doing it the way I've done it. There are also, besides gender differences, discipline differences. And Sanjay talked about some of that. This was one of his studies that he mentioned, the 28% hand hygiene in men and in physicians and 34% in nurses. But the culture on the unit made more difference than the discipline. So here's another study that showed that physician hand hygiene behavior varied in a single hospital from 4% on the GYN unit, dirty, okay, and 96% in the neonatal unit, clean, which is sort of the opposite. But you'd think they'd want to do more hand hygiene in the dirty unit, but maybe they're thinking it didn't make a difference in a single hospital. And hand hygiene practices varied between a mean of 33% and 77% between hospitals. So this is very consistent with the idea that despite the gender differences, despite the discipline differences, the culture on a local ward or unit or in a local setting has an important role. So gender makes a difference, discipline probably makes a difference, but it's probably confounded by gender because most places still have more physicians who are men and more nurses who are women. Most importantly, though, the unit culture clearly stands out, and it's consistent across countries, which is very encouraging because that means that if we have systems level thinking, we can think about systems level interventions to begin to change the culture with people's attitudes. So what is systems thinking? And this is from Don Berwick's work. A safety system is a set of managed interdependent organizational activities that reliably make potential errors visible, reduce the risks, and mitigate the effects of the errors. So here are some of the components. Specific and regular executive board activities. The boards read about it. The bosses know what's happening. They see the data. Ongoing, frequent, graphic, scientifically sound monitoring. And I put that in bold because that's one of the places where electronic monitoring and tools to provide this kind of information are very helpful. Detailed accident investigations. If there's an outbreak, what's the root cause? A safety system also includes ongoing processes for learning from the research, what went wrong, what didn't work, how are we going to change it in the future, processes for maintaining and encouraging a participative, you know what I mean, but getting together and doing it together. Okay, free of blame, alignment of internal incentives with safety improvement aims, effective, efficient prevention methods, and regular audits. So, since it's not possible and probably not desirable or necessary to observe all opportunities of any practice, whether it's hand hygiene or urinary catheter care, whatever. We need to look at meaningful surrogates and what's going to be meaningful and sufficient for providing people with the feedback, the data they need to make the changes that they have. So we've got to balance getting good data that is actionable with resource use and other priorities. And that's where electronic monitoring can contribute to the institution's safety system. It doesn't have to be electronic, but that's one efficient way to do it. And it does resolve some of the problems that John just mentioned about observation. A challenge, however, is also how the staff perceive them being monitored or observed. So one group did 10 focus groups with 86 healthcare workers in 3 hospitals, a VA hospital, university hospital, community hospital, and asked them, what are your concerns about electronic monitoring? Now, I don't know if any of you have had experience with electronic monitoring from the side of being the recipient, but these 2 things often come out. First of all, I don't believe it. You know, if we observe, we find out our hand hygiene practices are 90% compliance, but then you're telling me that it's 37%. I just don't believe it. It can't be accurate. Not me, somebody else. The other thing is, what are you going to do with the data? Is my name on it? Are you going to tell my boss? Am I going to get in trouble? So concern about punitive action. And this idea of big brother sort of watching me. Interesting, because in food service, it doesn't seem to be such a big problem. It's sort of accepted that you're going to possibly be monitored in your behavior in food service. But this group recommended addressing accuracy issues, first of all, making sure that the systems are correct and accurate, and transparent communication about what is the intended use of the data. First of all, why are you doing the monitoring? So Joint Commission now requires that accredited hospitals all have a plan for hand hygiene monitoring. That, I think, has had backlash, and we're going to hear from Joint Commission people over lunch, because if you have falsely high rates, it actually puts, people say, well, our rates now are reported to be 90%. We still haven't changed our infection rates. Therefore, hand hygiene does not work. And so you're actually creating a disincentive for doing hand hygiene. If it's for the purpose of education and feedback, and if all you're doing is regulating, I think that's a problem. Or for behavior change, then there has to be feedback. People have to know what they're doing, and they have to get transparent feedback about it in a timely way. If it's for monitoring trends, then you look at the trends over time, and the way you choose to monitor may vary depending on your reasons for monitoring. So the methods might be observation, how much product is used, how much soap, how much alcohol sanitizer, or electronic. It depends on the purpose of the monitoring, how much it's costing, and the feasibility. So another issue to consider is whether you monitor each individual, in which case each individual has a badge or some kind of a way of identifying them, or if you want to monitor an entire group. And again, it depends on your goal. If you want to give individual feedback, then obviously you need to identify people. There are then the concerns about Big Brother, et cetera. But that takes a huge amount of work on the culture to get people to accept that. Personally, I think it's a great idea to look at group monitoring, i.e. on a unit or in a particular ward, or that in an outpatient clinic or whatever, because then it's not one person pointing the finger and saying, well, I did better than they did or whatever, which can also be an advantage to have some competition. But you really need to think about whether you're trying to create a team culture where I own this responsibility and this is my part of it. So we need to look also moving from individual to organizational, the perceived threat, my health is threatened versus there is a relationship between what I do and what happens to the patient. Norms, do others expect me to wash my hands, or does the whole organization value hand hygiene? So, et cetera. We need to move from the individual to owning it as an organization. I'm not going to go all through all these things, but here are some of the challenges. If we don't have a connection with what the practice is with positive outcomes, if it's too complex and inefficient, if time pressure and high cognitive workload just make it impossible and can't be mindful, if there are few cues to do these kinds of things, or if there's inconsistent ergonomic design practice. And there are some systems where you can game the system. You can move around or duck under or whatever. And believe me, any gaming that can happen is going to happen, even though people want to do the right thing. So this I've found to be a very helpful kind of a tool. Basically, talking about how we can foster change. It's got to have all these things. It's got to have organizational learning. It's got to have feedback and reinforcement. It has to, I keep hitting John's head. I hope you're not going to get brain cancer or something here. I'm sorry. Lack of, local and focused implementation. And I got Paul that time. Okay. Frontline staff engagement, communication and collaboratives, and supportive resources and accountability. You need all of those things. And my feeling is that we have technologies and tools that can actually help in all of those areas, but we are naive, and we have been naive, all of us, myself clearly, for years, thinking that guidelines would work, techniques would work. Nothing works without the whole shebang. So, thank you.
How are you? Thank you, Christine, for having me. Really appreciate it. Honored to be on the panel with Elaine and John, of course. And thank you for the elevated degree. I don't have a doctorate, but that's okay. My son does. Anyway, really excited to try to give a perspective. Certainly agree with everything that has been said regarding moving from direct observation as the primary measurement mode for hand hygiene and combining electronic monitoring with direct observation, each for what they're best at. And certainly the behavior piece is key. And so we're going to talk about the importance of accurate and reliable measurement, potentially what could be the new gold standard, which is the combination, as an article that John just published a couple of months ago, e-monitoring plus direct observation. And then we'll talk about the electronic monitoring universe. What are the different technologies that are available? They're basically three buckets, and we'll talk a little bit about those. Emerging outcomes, we are really, really early. I really think back to, and I think it was about 93, 94, when Elaine convened the first alcohol symposium when she was at Johns Hopkins. And I remember at the time I was in the process of launching Purell for Gojo. And I remember it was so early when we walked into hospitals with alcohol, it was no, we wash with soap and water. And we're at that same border of change now, where the standard of care may be changing, but it's still very early. And then putting it all together, what does it take to be successful with electronic monitoring? As Elaine said, it's about a very, very holistic approach. It's not just about the data, but how do you use the data? How do you socialize the data within the culture? How do you make it part of the culture and therefore something that becomes automatic? And so those are the kinds of things we'll talk about, and we'll tell some stories. We'll tell some stories about hospitals that are achieving success and have published research. John quickly referred to the study that was done by Jocelyn Strigley and others in Canada, and what they did was they used a sophisticated real-time locating system, a tracking system that basically kept track of people, but it also enabled the ability to know whether or not a healthcare worker was in direct line of sight of the observer. And they found that compliance when the healthcare worker was in direct line of sight of their observer was 3 times more likely, 300% more. So, and now in Ontario, where this study took place at the University Hospital Network in Toronto, 1,200-bed facility, the Toronto Star picked this up and said, well, basically, rates that are mandated, they have to report rates to the Ministry of Health in Ontario, are basically wildly overstated by 300%. And Michael Gardam, who was one of the co-authors with Jocelyn, said, well, I guess if we're still having infections and we're reporting 90% rates, maybe there's something wrong with our measurement. And this led to action. Jerome Lease, who was referred to earlier in the day at Sunnybrook, developed a consortium of 5 hospitals who are now studying the use of electronic monitoring in 5 Toronto area hospitals to see whether or not they can actually influence change for the way hand hygiene is reported in the province of Ontario. So it's going to be interesting. That's an 18-month study that should conclude sometime next year. Anyway, speaking to the point that John made, combining electronic monitoring with direct observation, a study was done by Dr. Bill Kelly and Connie Steed and others at the Greenville Health System, and what they did was they combined e-monitoring, that is getting real rates in real time, with direct observation to identify barriers and obstacles, and they use that to give feedback to the unit and drive consistent improvement on the unit. So thinking about John's article and thinking about this paper and other work, it's likely that could become the future gold standard. Still a lot of work to do. So what does the electronic monitoring universe look like? There are basically 3 types of technologies. The first is a group monitoring, a non-badge based system. Elaine talked a little bit about the difference between group and individual, Big Brother, not having Big Brother. So there's group monitoring. There's individual monitoring, which can certainly be rolled up to group, basically using a standalone infrastructure, meaning it's a self-contained system. And the third type of technology would be individual or group that's also badge-based, but that relies on a real-time locating infrastructure. That is, it has a system that tracks people, tracks equipment, tracks patients and staff, and this is one of the apps that they use, like Nurse Call. They can use workflow efficiencies, and hand hygiene becomes one of those on there. And the basic way those systems work is that they capture the data, typically at the dispenser, transmit the data in real time to either the cloud or a server, and then a real-time dashboard is available almost in real time to end users, so they can take a look. Imagine having data immediately available so that you can look at it and not have to wait for the compilation of direct observation information. What to look for in an e-monitoring system? I think the must-haves are it has to capture 100% of all hand hygiene events. It has to include a behavior change system. It has to have a way to foster just culture or psychological safety. It has to have validated accuracy, and it must be evidence-based. And other considerations that you'd want to look for is what standard of care are you going to use? Is it going to be 5 moments? Is it going to be 2 moments? Is it going to be requiring hand hygiene product change? What's the reporting level going to be? Is it group or individual? What are different functionalities and so forth, and of course financial considerations. And I'll just do a quick touch base on some of the evidence that's emerging. This was one study showing the accuracy. Hand hygiene was measured 3 ways: direct observation on the top, electronically, and with video monitoring with actual video cameras. You can see that video monitoring and the electronic system were almost identical. Direct observation was overstated by about 47%. And the coefficient of correlation between electronic and the video validation was almost identical. Infection reduction studies. This study done by Dr. Kelly concluded that not only did they have a reduction of infections and costs, but they also had an impact on organizational behavior. Their actual numbers were a decrease of 43% in hospital onset MRSA with an associated $433,000 cost avoidance. That was published in AGIC of August last year. Other studies are available, and we have a complete evidence roadmap at the ECHO website, and that's available. I'm happy to send that out to everybody. About 20 articles giving the studies. Just a quick review of best practices that it's going to take to implement a system, and that's going to be you have to have top-down leadership support. If you don't have that, and it's not authentic and known by all, there has to be psychological safety, meaning anybody can speak up in a promotion of just safety culture. Direct observation has to be combined with electronic monitoring, and It's important that the data is used on a routine basis and that frontline staff is engaged. And so it's not just about the data, it's not just about the technology, but how do you approach it in a holistic way to make sure it becomes part of the culture on a sustainable way. Thank you so much for having me.
Well, thanks very much, panel, and thank you, Paul, for putting up the slide from the Toronto Star on the Ontario numbers. It leads right into my comment. A couple of comments. First of all, the gold standard that we talk about all the time, and there's lots of gold standards in infection prevention, and just like the U.S. got off the gold standard 40 years ago, we need to get off the old gold standards, I think. And so we have a major reset coming in the levels of compliance that we're going to expect. So in the old gold standard, we're falsely publishing 95% compliance. In Ontario, every hospital has it on the website. To do that reset down to 30%, or whatever we're going to see as the typical average with monitoring technology, that's a major shift. And the infection control practitioners that I've talked to are all afraid to address that issue. So I did a thing with IPAC, Toronto area, GTA, a few months ago, saying how can we all work together to collectively address this and let your C-suite know that those numbers that we've been reporting for all these years are not the right numbers. And just like penguins jumping off an ice floe, nobody wants to be first. So if we all work together, maybe we can address this. But even as a group, the group refused to take that on as a challenge. And that's going to be a major barrier, I think, to implementation. We've got to work to figure out how to address that issue.
Do you know Matthew Muller? Yeah. So he published a paper in JAMA, which I love, addressing this issue. He said that, and you're right about infection control people, they do not want to do this, partly because the system blames them they'll get in trouble. And so there are systems that are so risk aversive that they really know that the hand hygiene rates are not that high. And frankly, they sort of don't care. And until the system is such that it will actually make a commitment to not punish people, but turn it around and make it the learning organization, that's the problem, I think. And I remember when we first started talking about alcohol use for hand hygiene rather than soap and water, the biggest, the strongest talks against it were the infection preventionists, the infection control people, because they said, if we tell people to do alcohol hand rub, they won't wash their hands anymore, forgetting that it wasn't the process that was the outcome. The process is to get your hands as clean as they can be. So it's kind of like people who ran the trains who said, well, no, I don't want airplanes, but they forget it. They're in moving people, not, trains. Okay. So there have been cases where systems have been so resistant to actually fessing up to the problem that it's not going to happen. It's going to take very brave people to do it. And it's got to start, I think, with the system understanding that I don't think we should lower our things and say, we'll be happy if you go from 30 to 40. I think you should say our goal is X, and here's how we're going to get there. But acknowledging that, because until it's transparent, it's never going to work.
I think just to add to that, Alison McGee also in Canada, when she put electronic monitoring, and they went from direct observation rates that were being reported of 86% down to an electronic measurement of 30%. And she said something really compelling for us, and that was, well, the 30% is what matters to our patients. And if we're really at 30%, then we have a sense of urgency to improve. And so the message to Elaine's point to the staff was, it's not that we've gone down, we're measuring differently. We're using a different technique to measure. We're going from a few thousand audits a month to millions. I can share with you that hospital systems, that a 1,300-bed hospital system grew by 5 million hand hygiene events in the first year of putting an electronic system. You couldn't capture that type of data. So the wealth of data that you get when you have that type of 24/7 monitoring is amazing. So you have to make it very positive. To Elaine's point, you have to make it very, very non-punitive. And the fact is, it's about progress, not perfection. And this is where we really are. We're resetting the clock. We're not going to look back. We're going to look forward, and we're going to take care of our patients.
Something that I seem to hear is that there is a disconnect between hand hygiene and hand hygiene monitoring. And so a lot of the times when I'm talking with healthcare professionals and they're doing, say, wash in, wash out, well, then they think that that's the only time they have to wash their hands because that's when they're being monitored. When, if we could also start to, develop a training program that applies to everyone hospital-wide, these are the moments when you should be washing your hands regardless of whether or not that measurement is being taken, because you can't, in many instances, collect a measurement. John, I thought maybe you might comment on that.
Yeah, I very much believe in the WHO 5 moments approach, especially for teaching when hand hygiene should be performed. And so I think that even the many hospitals that prefer monitoring compliance on an in-out of the room basis, they should still be teaching the 5 moments in terms of when hand hygiene is indicated.
Just to add to that, there are studies that have shown that you can predict with pretty good accuracy a 5-moment denominator. There was a study done originally in 2011 by Steed et al., validated in 2014, and then revalidated in Australia by colleagues that Elaine referred to earlier. So there are studies that show that you can predict a 5-moment denominator, not just in and out.
I get that, but the point is that is to ensure that people are actually washing their hands regardless of whether or not they're being monitored, and it's changing that behavior. And Elaine, I think you were about to comment on.
One thing we have to be careful of too with the in-out is that our staff said, well, you're standing at the door, you're not going in, I'm not touching anything. So you're docking me for not touching anything. And we didn't believe it. So we decided to see how often it happened that somebody went in the room and actually didn't touch something. It was a lot more than we thought. We thought that most of the time somebody would at least touch the IV, something. But about, more than half of the time when they went in, they in fact did not touch a thing and walked out and just sort of stayed away. And that, so we have to acknowledge the fact that, we can't be, again, naive. We have to acknowledge what's really going on.
I find it kind of interesting. We talk about the healthcare worker quite extensively here today. But in reality, in healthcare today, the healthcare worker needs to be extended to the family. My family has had problems in the hospital, and the caregiver were my children, to my wife, and the family members. And then when I go into the bone marrow rooms, there are always people in there. What do you teach the caregiver family about hand hygiene, and how do you enforce that? That's a huge component of what we need to talk about.
Well, patient hand hygiene has just started to get a lot of attention. So one of the things we do now, and we went around some years ago and cultured patients' hands, their axilla, and their groin. And what we found is they were filthy. And it wasn't necessarily even that they came in filthy, but you know what? They're not getting baths as often as they used to, and they're not getting the kind of hygiene attention. Now there's such high-tech stuff. So people who are in bed for a week or so may get a bath a few times, or may not get a bath. So we now put hand wipes, hand sanitizers on everybody's trays for each meal, the patients, and we provide them for the patient's family, the sanitizer, things at the door. And there's a lot being done in hospital lobbies and so forth, and in rooms. But you're right. Although, frankly, there's not as much evidence of transmission within the family because, frankly, we live together, we share our flora. And so we're not as likely to have problems unless the caregiver, and this could be the case, is changing dressings so that you have open wounds, or handling the catheter, or cleaning around a PICC line, that kind of thing. So I think we focus more on healthcare professionals because that's where the data are, that they are the riskiest bunch. But we certainly need to pay attention to the families too.
And, some hospitals for some period of time now have prepared a brochure that is given to patient families as well as to the patient at the time of admission in an attempt to educate families about the importance of hand hygiene. And then Marianne McGuckin and others have not only popularized the idea of having the patients speak up to remind healthcare workers to clean their hands. I think this is a difficult thing for patients to do. Some of them are afraid to do it, but some families who are very involved in the care of the patient, the family members sometimes are also encouraged to speak up. And I think CDC's recent hand hygiene promotion program suggested that we talk to families and invite them to speak up when they see people not cleaning their hands. So there is some efforts, I think, to educate and get families involved, although I think we need to do a lot more along that line.
So you've talked a lot about compliance and whether the healthcare worker washes their hands when they're supposed to, but can you comment a little about on when they actually do wash their hands, on whether they're doing it effectively and whether they're getting their hands actually clean?
We know that from studies published over the last couple of years in particular, that healthcare workers often do not clean their hands in a manner that's recommended. A nice paper from Germany recently showed that the average amount of time spent doing a hand hygiene episode, this is with an alcohol hand rub, was 7.6 seconds, with some people doing it as little as 2 or 3 seconds. And it's clear that if you apply an appropriate amount of hand hygiene sanitizer to your hands, enough to cover all surfaces of your hands, that it should be almost impossible to rub your hands until they're dry in less than about 15 seconds. So I think some people purposely apply a small amount of gel to their hands because they want to hurry up and finish their hand hygiene event. So we know that they're sometimes not taking the correct amount, and sometimes when they do it, they miss their thumbs and their fingertips. So there's, I think, more attention in the last couple of years to the volume that people apply to their hands and how completely they cover their hands. And I think we need to work a lot more on technique.
How do you quantify from regulatory perspective, or however you want to use the data, whether it's for education or for process improvement, especially for electronic monitoring? How do you quantify the specific denominator in achieving compliance? Especially, there's so much factors to consider other than culture. There's also the units or the shift of the time difference, like first shift or night shift or day shift. How do you get that compliance perspective that you need to demonstrate to regulatory agencies, especially Joint Commission, when they wanted you to present that compliance?
I'm not sure. Are you asking how do you get a denominator
Yes,
for a
'cause,
percent?
denominator in the sense that you have 5 moments of doing hand washing.
Uh-huh.
So to your point, Elaine, a while ago about going into the room but not touching a thing or not touching the patient, versus getting the compliance of using the the electronic monitoring and getting the hand hygiene perspective, how do you correlate that to just getting inside and
Yeah, well, I'm sure Paul can talk more about this too, but there are all kinds of ways to model how often a hand hygiene episode should be occurring based on the number of patients and the severity of illness of patients and so forth. So some of it is based on sort of modeling and observational data. And as John showed some data, if you just monitor a couple of moments, you can predict how many they're likely to be needed. So Paul probably has more.
Yeah, there have been studies done developing predictive algorithms that when you know the staffing level, patient to nurse ratio, and you know census on the unit, you can accurately and reliably predict how many times people should, based on the WHO 5 moments, wash their hands. It's not an exact number, but it's statistically accurate, reliable, and reproducible, and can be used as a 5-moment denominator with electronic systems to produce an accurate hand hygiene rate. Again, it's predictive. It's not exact, but it's very, very accurate and reliable, and especially compared to direct observation, a much better way to get the real rate.
I'd like to thank the panel for their time.